Yeah, better do that right. This, yes, it would be a problem if we approve something and we didn't have a quorum. That would be a problem.
It would not look great.
What happened when Aaron got town?
I know, and it's kind of waiting to see if we had an answer on what the quorum was, but it's. I will just delay approval of minutes, but I will do a roll call. Let's close this door. Okay, good afternoon, everyone. It is little past 1 o'clock. I'm Joanne Burke. I have been asked to chair the meeting this afternoon because our chair, Megan Smith, is unable to be here, and our past chair is unable to be here today. So I'm chair of the Commission on Aging and also sit on the Choice Board as well. So in that position. So we'll call the meeting to order this afternoon. And I am going to delay the approval of the minutes.
It's a majority of voting members is considered a quorum, Dr. Burke.
Okay, I will call roll this afternoon. Megan is not here. Jim is not here. Senator Charbonneau.
I'm here, I am on here, yeah.
Oh, wonderful. Thank you.
Oh.
Senator Jackson. Representative Claire. Leslie is here. I am here. Stephanie is here. Beth Schoenfeld. Jake Sipe.
Hi, I'm here.
Okay, Jake. Great. Giovanna War. Okay. Okay, we will, does anyone have any amendments or corrections to the minutes? We're going to file them because we don't have a quorum. Okay, we will file the minutes and they can be approved at the next meeting. I do an update to today's meeting regarding our member recruitment. Senator Jackson was recently appointed to the Choice Board by Senator Greg Taylor. Senator Jackson serves Indiana Senate District 34, which includes the east side of Indianapolis, portions of Lawrence, including portions of Center, Washington, Lawrence, and Warren Townships. This is Senator Jackson's first meeting. So welcome, Senator Jackson. We do have applications pending with the governor's office to fill the following: one provider who provides services under the Choice statute, one citizen nominated by one or more organizations that represent individuals with disabilities, including individuals who are less than 18 years of age and have statewide membership. A nomination was received from the ARC of Indiana. The following vacancies remain and are in need of applicants. 2 vacancies for a citizen nominated by 2 or more organizations that represent senior citizens and have statewide membership. 1 must be an individual that is a recipient or the caregiver of a recipient of choice-funded services. And we also have a vacancy for one licensed physician, physician assistant, or registered nurse who specializes either in the field of gerontology or in the field of disabilities. And we really, really encourage you to, if you have some folks that you would like to bring forward, we really, really want to get these vacancies filled. So just asking you to give that some thought, please. Any questions? Okay. Well, this afternoon, we have a presentation from Dr. Steve Council, who's Medical Director of the Division of Aging, and he's going to give us an update on the ABC Community Program. Welcome.
Great, thank you, Dr. Burke. I think I've got the slides in place. Good afternoon. It's a privilege to have the opportunity to present to the Choice Board, Indiana Family Social Services Administration, and about ABC Community. In the agenda, it has it deemed as an update, but the last I presented it was in May 2021, so a little over 3 years ago, so likely not an update for most of you, and brand new. Also, it has me down as the medical director for the Division of Aging, Family Social Service Administration, which I am, and I'm contracted most of my time these days to serve in that capacity. But this presentation and ABC Community is with my IU hat on, my Indiana University hat on as professor of medicine at IU School of Medicine. If I'm able to take one hat off and put the other one on, I think I'm always wearing both, I think, in recent years. So ABC, I've got a couple objectives here. Next slide. So in education and training, I'm always caught up on, well, what are the takeaways that you want people to have after the presentation? So I'd like you to be able to list the key components, essentially know what ABC Community is and how it's delivered by Aging Brain Care or ABC Care Coaches that are employed by area agencies on aging. And the second, I'd like you to know about the results that we've had from 2 grant-funded projects over the last 4 years, including reduction of dementia symptoms in people living with dementia and reduction of stress in their caregivers, and increased quality of life for Hoosiers living with dementia and their caregivers. And then finally, I'd love your feedback on adding ABC Community as a service option under choice to enhance support available for caregivers. So with that, an introduction, some of this is well known, I'm sure. It's also taken from our Indiana's Dementia Strategic Plan and information from the Alzheimer's Association chapter of Indiana. But over 110,000 Hoosiers age 65 and older have Alzheimer's disease, and additional Hoosiers have other related type dementias, all of which typically cause cognitive impairment related to functional decline, and thereby increasing dependence on others for their activities of daily living. The caregiving role is often complicated as well by needing to manage chronic health conditions in participant, as well as those with dementia, behavioral symptoms, and mobility complications. Next slide. On the caregiving side, the Alzheimer's Association cites over 216,000 family caregivers in Indiana, providing hundreds of millions. I think they quoted 362 million hours of unpaid care to Hoosiers living with dementia. And we know that this role can be very gratifying, but it can also lead to undue stress, depression, and poor physical health on the part of the caregiver. We've had a longstanding recognition through the Dementia Strategic Plan and work beforehand of the paucity of dementia-specific training and supports available in Indiana to caregivers. And so that's what I'm presenting today is the ABC Community Solution. Next slide. So I'm going to present two projects that we've been funded for through Indiana University for implementing the ABC Community Program. And this first one was what I provided the initial presentation 3 years ago to the Choice Board, funded by the Administration for Community Living and the Alzheimer's Disease Program Initiatives track. And we called it Strengthening and Expanding the IU AAA or Indiana University Area Agency on Aging Dementia Capable Home and Community-Based Services System. A mouthful. So since we've essentially now calling this ABC Community. Next. So what does this involve? Initially, we started out with existing partners out of Indiana University Geriatrics and Center for Aging Research and Center for Health Innovation and Implementation Science, Eskenazi Health, and the Sandra Eskenazi Center for Brain Care Innovation and the Primary Care Community Health Centers, and a longstanding partnership with SACOA, Aging and Home Solutions, as the Area Agency on Aging in Central Indiana, as well as the Aging and Disability Resource Center, and providing care management to participants of the Age and Disabled Waiver Program. And additional partners, the IU Geriatrics Workforce Enhancement Program and the Greater Indiana Chapter Alzheimer's Association. So all those partners were already working together. That was the established dementia capable system. Next slide. And so under this grant, we were to expand that and strengthen that system. So new partners were 4 additional area agencies on aging. Up on the north, Area 2, Real Services, Area 3, Aging and In-Home Services of Northeast Indiana, Area 6, Lifestream Services, and Area 11, Thrive Alliance. In addition, working closely with Kristen Leis and the Indiana Association of Area Agencies on Aging, Dementia Friends Indiana, and our evaluation was conducted by Ellen Burton and colleagues at University of Indianapolis Center for Aging and Community. Next. So the goals of this project were, and I skipped over this, but this was a 3-year project that ended about a year ago. So that's where we're presenting that today. The goal was to enhance, strengthen, and expand the existing ABC Community Program to maximize the ability of people with dementia to remain independent in the community. And it had several objectives, but the one I'm focusing on here today is number 2, to provide dementia training to family caregivers. Next. So our focus under this program was to support caregivers and waiver participants, Asian disabled waiver participants with dementia. And to do that, we deployed care coaches who were employed by the area agencies on aging, those 5 that I listed. And the criteria for those was really looking at more of a community health worker, high school diploma, associate's degree, or a certificate as a community health worker. So we're looking at to expand this program that was originally founded in a health system and more of a medical model to look at providing care coaches from the community and community-based organizations, specifically the area agencies on aging. They went through a training program previously provided under the ABC Medical Home Dementia Care Program of Eskenazi, which included intensive 5-day training. We had to start this program in the midst of COVID. So what used to be in-person training all went virtual. So we split it up between the 5 days into 10 half days of virtual training for the 5 care coaches and their 5 project site coordinators at the AAAs at that time. So what is ABC Community? It's the new name for Caregiver Stress Prevention Bundle. And this is something that was developed out of IU Center for Aging Research. Back in the day, I was involved, but the program was led by Doctors Chris Callahan and Malaz Bustani. Dementia, internationally known dementia care experts. And so they particularly were looking at how can we either prevent or reduce the stress involved with caring for someone with dementia over time. And in addition, how could we potentially reduce adverse symptoms of dementia, such as agitation or aggression or sleep problems or depression that often arises in these persons. So there's 4 components, so 4 key components. This was one of the learning objectives here. Looking at, and not everybody gets each one of these, but these are delivered by the ABC care coaches who've been trained up to provide counseling and education and referral, an ongoing relationship with the caregiver and the person living with dementia, to provide education on communication techniques, assistance with preventing behaviors and the like, as well as development of crisis plans. For example, if the person living with dementia has to go to the hospital, or if the caregiver has to go to the hospital, having things backed up and set in place so things are covered during a crisis. In addition, something that has been found to relieve caregiver stress over time and help people go the distance is to have regular caregiver time off from their caregiving duties. And ideally, under the program, we would look to an 8-hour day or weekly of time off by the caregiver, whether it's another family member helping substitute and provide that caregiving, or paid help or attendance to adult day service or the like. And then finally, a support group participation. And the Alzheimer's Association and other groups provide support groups out there that the caregivers and sometimes even the care participant can participate in. So that's the caregiver stress prevention bundle. And the ABC community is when that's provided by Area Agency on Aging, ABC care coaches. Next. And so what was our methods under the larger Administration for Community Living grant? So we helped the area agencies on aging develop a job description for their care coaches and go through the hiring process and orientation. We had care coaches hired at each of the 5 area agencies on aging involved in the program. We provided that initial intensive training, but in addition, booster training every 6 months. And we held virtual case conferences twice a month. These are very important, where the care coaches would come with complicated or challenging cases or success stories and share amongst themselves with dementia experts at Eskenazi Center for Brain Care Innovation about those people so they could better serve and meet their needs. And finally, the IU Geriatrics provided the technical assistance to the area agencies on aging on setting up this program, and including continuous quality improvement efforts. Next. So we targeted, as I mentioned earlier, initially Asian disabled waiver participants, which oftentimes are underserved, especially their informal caregivers. And so helping support those dyads, the people living with dementia and their caregivers, by the Area Agency on Aging care coaches serving people in their planning and service area. They would have a minimum of a monthly contact in the first few months and then go quarterly. But if they were outside the green zone, and I'll explain that a little bit further, but if they, on their initial assessment, they scored high on the stress levels, they got more intensive weekly contacts, ×8. So the routine was to really work closely with them if they were experiencing stress and challenges at the time, that they would get more detailed and intensive support and counseling during that time. So the goal was to help people if they were outside the green zone to come down within the green zone, and those that were already in the green zone, it was really in the prevention mode and to anticipate and allay issues. So the HABC Monitor is one of the unique aspects of this program developed by IU Center for Aging Research. It's actually a pretty brief questionnaire of 31 questions and 4 subscales, and it can be used both for assessing the individual and the caregiver and their needs and to drive the care with using protocols and such by the ABC Care Coaches, but it also serves as an assessment of results and measures stress in the caregiver, but also quality of life and dementia symptoms. And so you can see there's 4 subscales: the cognitive subscale, functional, behavioral, mood, and caregiver subscale. When you use all 4 of those subscales to get the caregiver stress score. And so when the score is above 14, so 15 or higher, that's outside the green zone and deserves a more intensive intervention. And if they're in the green zone, 14 or below, then that's more in a prevention mode. But still proactive contacts and working together to plan ahead. Next. So the population characteristics, this is the first 407 that we served. We served almost 500 participants living with dementia and their caregivers in the Administration for Community Living grant. You can see here that most of the participants with dementia are over 60 and female, and a third minority. So again, this is looking at providing access across the board to waiver participants, which happen to be typically a more diverse population. You can see we had Hispanic or Latino and Black or African American participants and caregivers engaged. Most in this startup first project were urban, so 91%. That's defined by living within, I think, 10 miles of 50,000 population area. Top right, you can see that most people living with dementia were the parents of the caregiver or the spouse of the caregiver. So that's adult children and spouses doing most of the caregiving. And most of the caregivers did live with the participant living with dementia, but we did serve people living with dementia who were living alone with the caregiver not on site. And that was a good proportion, and actually something required by the Administration for Community Living, because we know that up to 30% of people living with dementia actually live alone. There's another. So did we implement the key components of the ABC community model? And so you can see off to the left, we tracked this by the ABC Care Coaches to make sure they were delivering the program as proven to work. And all 4 of those things are not intended to be provided to all participants and caregivers. Certainly counseling and education, most people will get that actively throughout all of their visits and contacts. And crisis plans, we really look to optimize for everyone, but the regular caregiver time off and the support group participation is less often. You can see on the right-hand side, when this program was first developed with in-person visits and not telephonically, that the engagement was far less. And the program still worked in terms of reducing caregiver stress. We found doing this telephonically and with the Area Agency on Aging Care Coaches that we really got high levels of engagement with the caregivers and implementation of the different components. The support group involvement, this you might guess, having done this during the pandemic, the support group participation really dropped off from previous, but I'll show you in our recent project where that's really come back. Next. So we were providing the program and that was 3 months results in 224 people that we had. The next slide shows, I think, some of the results. So this is those results in people that we had, the first people that 224 people that we had both a baseline and a 3-month assessment in. And you can see the first two bar graphs there. That's caregiver stress reduction. So we had 156 people there to the far left who started out at baseline that were outside the green zone. So they needed more intensive work right from the beginning. And you can see even by 3 months, that only that 38%, almost 2 out of 5 were already in the green zone. So within 3 months, we were getting some results there with those folks. And then the other side of things, so people, the 68 people who started out in the green zone, really shifting into a prevention mode. And so that's the caregiver stress prevention. And in all but 1 or 2 of those, I think, we were able to keep them in the green zone within the first 3 months. Next. These are, I won't go through this in detail, but you can see each of the subscales we were able to monitor. And looking at the percent change, you can see that there was a significant reduction in the scores on each of those subscales. And with the total score having a 29% reduction just in the first 3 months. All statistically significant from the scientific standpoint, but also from the clinical standpoint. We know that a reduction of about 5 points is clinically significant in terms of realizing that, yes, someone's stress level is down. And so you can see the total score went from about 24 to 17, or a reduction of 7 points in the first 3 months. Next. And then looking at average scores on the HABC monitor, you can see in the whole group that we had HABC monitor scores on at baseline, 407 at the top. And then at 3 months, that 224. So the average was down significantly there in that first 3 months. And then it stayed down over 6 and 12 months. And then the blue line, the dark blue line there, as for people who, the 72 individuals and caregivers that we had, all 4 data points, baseline, 3, 6, and 12 months. And you can see for them as well that they dropped down into the green zone at 3 months, and then were able to stay in the green zone over time. Next. So what we found really that, and we concluded, was that this was a scalable community-based, so based out of the area agencies on aging, not the health systems, and a telephonic version as opposed to in-person home visits. This was a scalable version of the collaborative dementia care model, or that ABC community, successfully implemented through the university AAA partnership. And we've made several national presentations on this since that administration community living project ended. Caregiver stress was notably, as measured by that HABC monitor, reduced in those caregivers of the participants with dementia. So implications. So on the heels of that, we were wondering, well, how are we going to keep this going? We had enrolled almost 500, and we had maybe 200 active participants still last summer. And along comes Leslie Huckleberry and the Division of Aging and Indiana Family Social Service Administration, looking at, wow, could we use some of those American Rescue Plan dollars under the Home and Community Services spending plan? So that's what funded the second project. Potential sources of long-term funding that we're really getting to here is the end of the Indiana FSSA project is December. So we have 3-4 months left. And then we're really looking towards Older Americans Act funds under the Title III Family Caregiver Support Program, potentially the Choice Program, and a little further out, making changes and adopting this as a waiver service under the Pathways waiver, and then finally contracts with Medicare and or Medicaid plans. So the second project is we just called it out front, ABC Community. It's the same program, continuation of the Administration for Community Living grant, as well as an expansion. And so this was enhanced support for informal caregivers. And again, targeting that underserved population of waiver participants with dementia and their caregivers. Next. So I'll be brief here. This is pretty much a duplicate of the initial project, but to sustain the original 5 area agencies on aging program and expand to an additional 5 area agencies on aging. So we have a total of 10 planning and service areas covered in this project. And to strengthen the support, again, for caregivers of individuals with dementia and maximize their ability consistent with the choice program goals of people living with dementia to remain in community settings. Next. So this lists the new area agencies on aging, and I reproduced the map and tried different colors and put a white asterisk next to the new area agencies on aging, Area 1, which has a new name. I'm going to have to update this slide. It's Co-Action now, right? And Area 4, Lifestream in Area 9, and Generations. We went south in a good way to Area 13 and Area 14. Next. So as of July, we had enrolled 177 new people under this project, funded since last October. And people being served and their caregivers looks pretty similar. We do have a more rural or a lower urban representation. You can see down at the bottom left, expanding to some of these other area agencies on aging. And we're also been starting to serve people receiving care management for Older Americans Act services, such as home delivered meals, or those receiving choice services and such. As long as they're getting care management through the area agency on aging, we open things up for them to receive the ABC Community Program. Next. So fidelity was just as good, if not higher, than in the original project. You can see there the support group participation now 46% in these people that we have results at 3 months. So getting outside the pandemic and everybody getting back out, and a much more uptick in that participation. And next. And so results, you'll see that this looks pretty similar, and this is on the first 67. So a smaller number than in the original ACL project. But you can see in those people that were outside the green zone starting out, 3 out of 5 here now were in the green zone after 3 months. And those people that started out in the green zone, all but one here there, I think, are still in the green zone at 3 months. So seeing very similar results and pretty startling results, actually, from looking at the original studies out of the health system, seeing that the stress levels come down faster and in a greater proportion of caregivers than served under the original health system program studied 20 years ago now. Next. So similar graph. This is just the first 3 months in these 67 folks, but you can see we're seeing an impact already. And I think we got a couple left. So that's ABC Community, the objective. So hopefully you've got the key components of ABC Community down and realize the results that we've seen consistently across both projects. And now really look forward to your feedback on the program and hopes of establishing this as an optional service under the choice program. Questions, comments?
I'm waiting for others before I put this chair hat on, but let me say, this is really impressive. Obviously, it's a very robust evidence-based program. very impressive results from this. And as we deinstitutionalize care of people with dementias as well as other disabilities in Indiana with the older adult group, we're relying more and more on family caregivers. And the fact that you've actually seen clinical results here, more than 5 points in your data improvement is really impressive. So I think it's a really strong case for expanding the funding for this, and with choice funding being able to be accessed before people get more frail on the Medicaid waivers, it would seem like that would be a very, very strong argument for tapping the choice funding for this program. That's my
Yeah.
other people weigh in on your thoughts.
Appreciate those comments, Dr. Burke. Yeah, it's been an extremely rewarding program with extensive collaborations across the state, as you can see, and between the university and the area agencies on aging and other dementia-related organizations and agencies. And it's really truly homegrown in terms of the initial intervention was first developed at IU Center for Aging Research here in Indiana, and now is actually being, it was used to inform the GUIDE model, the guiding improved care of people with dementia through CMS, a recent GUIDE model that has come out under Medicare as an 8-year demonstration. So I think it's a lot we have to be proud of here in Indiana about this type program, and yeah, it would be tremendous to have your support in continuing it here in our state.
Thank you, Dr. Council, for
Yeah.
your presentation. I can't believe it's been 3 years since you first presented this, but that sounds about right. So for the population that has been a part of the pilot, what happens once the pilot ends? Maybe you covered that and I missed it.
Yeah, no, that's what we're looking at now. We've got 3-4 months left and trying to determine whether we need to stop enrolling new people and just serve them out till December, or whether we can continue to enroll new people with a transition to either Title III-E service support or the choice program or philanthropic dollars by the area agencies on aging or what have you.
So what's the barrier to making it a choice service?
I think we're in good stead in talking with Aaron and Leslie.
I
Yeah,
can chime in
go
on that. I
Yeah.
think we're having discussions kind of from a policy standpoint and wanted to bring it to the board before making a final decision to see if you all were supportive of that, and then would continue forward with the final decision and doing what we could to implement it.
Yeah, but there's nothing statutorily that would prevent it from being part of choice, right?
Correct.
Yeah, so I say let's do it.
Yeah, thanks for that. Yeah, we've already been working within the CAMS care management software system through the area agencies on aging and collaborating with care managers and such. So there's some tweaks that will need to be made to CAMS and some logistics on the area agency on aging side, how to build this into Title III-E and choice service reimbursement, but we don't see any major hurdles.
What about making it a waiver service under
That's
Pathways?
the end game, I think, also.
So that has to be further discussion. It would be a waiver amendment. There is a service somewhat similar to it on the waiver today, but it's case management entities don't provide the service. I think it's structured family care entities that do. So I think that's a future conversation. I think in today's climate and budget, it's not something we'd move forward on today, but that's not to say it would never be part of the waiver.
Well, talk more about that. Why wouldn't we move forward with it if I mean, it's evidence-based. You've made the case for it. Why would we not move forward?
I mean, for any additional service that we add, we have to do a fiscal analysis as well and make sure that we have the budget to support it. And so as we're dealing with the budget of the waivers at the moment. We're not looking to add any new services at the moment.
Wouldn't this be part of the Pathways program?
It could be part of the Pathways waiver.
Right.
Yeah.
So what's the concern?
You would have to add it to the waiver. I mean, it would be a waiver amendment. We
Right.
have to do a fiscal analysis and make sure we have the budget to add it to the waiver.
I thought we were providing, under the new managed care model, we were providing a capitated rate.
We are, but there would still be, that still would have to be factored into the capitated rate. So I mean, if you add a service that we would then expect the MCEs to cover, that would then trigger kind of reviewing what that rate is and if that rate would be appropriate to cover an additional service. And then we have to do the amendment with CMS and
Yeah, except
work
it's,
through all those things.
but it's not necessarily fiscal additional cost. It could be analyzed as a net savings, right?
Overall, it may end up that way, as these programs have shown. We weren't unable in our study set up to show delay or avoidance of nursing home placement. But that's certainly been correlated with these type programs across the country in recent years.
Yeah. So I'm all for adding it to the choice program. I think we should do that immediately, unless any other members of the choice board see a problem.
I fully support that.
But I would echo a concern that I and others have expressed previously about putting additional pressure on the choice program and the lack of coordination now between choice and waiver because of the separation of those two programs. So I think this is just the latest, greatest example of that problem.
I mean, I think part of the benefit of this particular service and putting it with choice is you can support folks before they reach nursing facility level of care. So we could look at this as an early intervention tool
Yes,
as
or
we think
even
about
Medicaid.
choice.
Mhm.
Yeah, as we think about choice, supporting folks before they reach that level.
Well, I think it's absolutely an early intervention tool. That's why I'm saying I think that you could make an argument that it is cost neutral or even would generate cost savings. And I think Dr. Council is seeing that same potential. I don't want to speak for you, but you kind of lit up when I said that. So
Yeah,
I
yeah, no,
know.
you're right on.
I know your passion for this and love it. What I'm getting at is that there are folks who are being served and who will be served under the Medicaid waiver through the Pathways waiver who could benefit from this. So if we make it a choice service, then how do those individuals and caregivers benefit from it with the lack of coordination between Pathways and choice?
So are you talking about folks who could be on waiver and also getting the service under choice?
Sure. I mean, that's why I'm saying I think we should make it a waiver service. We should do the waiver amendment sooner rather than later. So that there is an opportunity for those individuals and their caregivers to benefit from this the same as choice clients. Otherwise, I mean, I guess the AAAs can provide this as a choice service to waiver recipients, but that's what I was saying earlier. It's another example of that disconnect
Yeah.
because under the old model,
Using choice dollars instead of waiver numbers. Yeah.
well, and under the old model, when the AAAs were administering the A&D waiver, they could, if this had been rolled out as a choice service, but not a waiver service, they could have provided it to waiver clients using choice dollars when appropriate because they were serving both, but now they're not serving both. So there's a disconnect. That's what I'm asking about.
Yep. And that's a lot of some of the transition we're looking at, having, we worked through in July 1, when so many people moved to the Pathways Medicaid plans for their service coordination of the waiver. We're definitely have a continuation of support and services for those folks, but working closely with the health plans to continue to follow those folks. But I think those issues are really key long-term.
So part of your cohort include your cohort includes a subset of Pathways participants.
Absolutely.
You said you had what, 500 total?
Initial and a couple
200.
hundred now, so, yeah.
So how many of your initial and how many of your current 200 approximately are Pathways waiver
That's
participants?
a good question. It's probably the majority, as that's been our target, population to serve from the beginning. And we have about 280 current active participants in the program.
Your target population was waiver.
Yeah, Asian disabled waiver participants with dementia and their caregivers was the original 4 years ago,
But not choice.
not choice, no. Only recently we've expanded it to people getting choice or Older Americans Act,
Okay.
home delivered meals, those kinds of things.
Well, all I'm saying is I think it should be a choice service and a waiver service. So I don't know what bureaucratic hurdle we have to clear to seriously to pursue it as a waiver. I mean, who has to ordain that? The secretary?
That's part
The
of it,
governor.
the CMS has to approve it. We have to put it in the waiver amendment and kind of work through those processes. It has to get approved by state budget committee, I think. So there's,
It's about a year-long process, I think,
it kind of depends, I mean,
at a
on
minimum.
what the waiver amendment timing is with that sort of thing. And
Yeah.
Yeah.
we can get it for our budget committee and get through an analysis to get everything.
Well, with the potential impact of this on the number of people needing the service, it does ramp up the need to address this sooner rather than later. Because the significance of quality of life here improvements is palpable. And we sit here with, it's hard to watch this. We sit here with some interventions that can be very helpful that have resided in a part of the state. And we've got need across the state, and now it's how do we extend this? So the impact could be so immense that I agree. I don't think we can wait. I'm sure nobody wants to jump right in to go through all this again with more approvals, but the impact would be great across the state. So I support the idea of moving on to try to get funding through waivers too. Choice and waivers.
I can
Because
take
as
that
I
back.
said this
That's
morning, I'm
okay.
right at the top of the baby boomers. So this is just starting, so, yeah, it's my plea.
Well, thank you for that, and I appreciate the opportunity to present that to you and the work by people statewide to make this happen. So thanks.
One other question, I almost forgot. One of your slides, you talked about crisis plan.
Yes,
So can you talk some more about that?
it's about whether, especially if a caregiver has a health problem, and so who's a sub in, or if a person with dementia needs emergency department or a hospital, so that documents and things are available and ready at the will, but also crises around driving decisions, when to stop driving, financial, legal issues and planning ahead. So there's about 6 or 7 different kind of crises included in that part of the program.
Yeah, I think that's probably an underappreciated part of what you've done.
Yeah.
That's something that if this were to be rolled out widely, I think that could be one of the most valuable parts of what you're doing.
It's definitely a key component that can help prevent and relieve, stress and improve quality of life, where people just kind of see the future and feel prepared
Well, prevent stress
and
and
supported. Yeah,
potentially prevent, injury.
yes, car accidents.
Well, and other sorts of injuries,
Yeah.
and institutionalization. And
Yep, yeah,
I think that goes to the cost factor.
very much so.
Well, you're doing great work.
Appreciate it.
Thank
Thanks
you.
a lot. Yeah.
Thank you so
Thanks,
much.
Jessica.
Really appreciate it, Dr. Council. Okay, we will return to some housekeeping things, but I want to move on. I will get there. I will want to move on to our next presentation and discussion on the age-restricted tax credit applications. Jake Sipe, are you on?
I am. I'm here. Thank you.
All right. Moving it on to you.
Okay. Yeah, I was asked to give an update. Currently, our most powerful tool to create affordable rental housing in our state are federal tax credits. And at ICDA, we administer those in a couple of different ways. One of the more popular ones is a tax credit called 9% credits. It's a very competitive application process that we have for those. And some of those applications are intentional and committed to doing age-restricted housing. And that could be 100% at 62 and older, or 80% at 55 and older. And so with that, this year with our 9% application, those applications came in at the end of July, and we'll be making awards on November 21st. We'll be making a recommendation to ICDA's Board of Directors for those. Of those 37 applications, 12 of them were for age-restricted housing, and some of them were for new construction, and some of them were to preserve and rehab existing housing. So I'll just kind of just go through the list, the 12, and give you an idea of kind of where they are around the state, and they're under review right now. And so these are just the applications that we have. So we have an application from Bluffton Senior Apartments. It would be 46 units. Durbin Plaza in Lawrenceburg would be 52 units, and that's new construction. I should also mention Bluffton was new construction. The Flats at Switch Yard is in Bloomington, 19 units, and that's new construction. Grace Point is in Washington. It was 44 units, new construction. Hawkins Homestead in Rochester, it'd be 35 units of new construction. Historic Jeff Center, which is in Lafayette, it's an existing affordable housing property of 74 units, and it would be substantially rehabbed. Limestone Edge is located in Bedford. It's 32 units and new construction. Residence at 845 is in Shelbyville. It's 56 units, new construction. Spires Senior Village in Oldenburg. It's using a historic structure on the campus there. It would be 65 units. Like I said, that would be taking an existing building that's historic, that's currently sitting vacant, and reusing that for senior housing of 65 units in Oldenburg. Tyner Senior Housing in Hartford City, another historic building that would be reused and created 32 senior age-restricted housing units. And then Walnut Ridge is located in Indianapolis, and it would be 78 units of preserving existing housing for substantial rehab. So those are the 12 properties that we have that are that have committed to being age-restricted. So there's those 37. Another tool that we have that is highly competitive, we're very fortunate to have a state tax credit that mirrors a federal tax credit with multifamily bonds. These bond deals are usually a little larger, over 100 units or so. And so we received 18 applications for the state tax credit in the multifamily bonds. Of those 18 applications, 4 of those are for age-restricted housing. They requested, the 18 had requested 276 million in bond volume. It would, if we had enough credits, it would create or preserve almost 2,000 units with total development costs of almost $500 million. But of those units that we have, I'm sorry, there's actually 3 out of the 18. One is located in, that we're reviewing currently, called Allen's Place, and it's in Clarksville. It would be new construction of 150 units. The other one is Memorial Place. It would be 84 units, new construction in Hammond. And then another new construction would be Ritz on Illinois in Indianapolis, and it would be 101 units. So these applications are currently being reviewed. Again, like our other credits, we'll be making a recommendation to our board on November 21st for those. We have the state broken up into 5 regions to ensure that we have some geographic distribution of these state tax credits. We'll be able to do 5 developments. Like I said, there's 18 applications, and we have the state broken up into 5 regions: a northwest, a northeast, a central, a southwest, and a southeast for those state credits. We have a non-competitive round for our bonds that doesn't use state tax credits. And those applications are rolling. They come in at random times. We currently have 11 applications, and 6 of those are age restricted. And so I'll just go through the list here real quick and kind of give you an idea of where these applications are coming from. Cambridge Squares in Bloomington is 152 units, and it would preserve, rehab those units. So those are existing units, senior in Bloomington, that would go through substantial rehab. Carriage House of Glendale, those are 204 units in Indianapolis. It would be a rehab. Arbors of Southtown Square Apartments, it's 212 units. And those, again, that's another rehab application that we received. And then the final 3 are affordable assisted living. And I'll go through these too. Vita Lifestyles would be in Lafayette. It would be 142 units of affordable assisted living, new construction. And the other one is the Vita of Westfield. It'd be 164 units, again, affordable assisted living, new construction. And then the other one that I think this is a first for us, and I hope we get to see more of these. This is bundling 2 existing affordable assisted living properties. One's in Yorktown and one's in Union City, to substantially rehab the properties. There's a total of 122 assisted living units there. And so we're going to provide the funding here to preserve and to rehab both of these assisted living properties, one in Yorktown and one in Union City, again, for a total of 122 units. So those are the applications that we have received, and they're currently under review. So just a quick update on kind of where we are with those applications and where they are around the state.
Okay, any questions, comments for Jay?
Thanks for that update. Is there a list of all the things you just presented? You were reading from something. Is it online where we can go look at it?
Yeah, we have a spreadsheet for each one of those. I can put a link in the chat here, or I can send it over. And there is a link that we keep these properties posted on there. And they also it goes into a lot more detail in terms of number of bedrooms, the bedrooms, 1s and 2 bedrooms, 3 bedrooms. It also breaks it down into the median income. So some of the units will have a certain percentage of the units at certain income levels. There's the developer information. So who is the developer? There's additional information on total development costs. So if you're curious on the total development cost, and most of these deals also have other IHCDA financing on them other than just the tax credits or the bonds. So IHCDA has a development fund, and we have some other soft gap financing. So there's some requests in for those dollars as well. So there's a bigger spreadsheet of each of these application rounds with each development and a lot more information for each specific development. You
just touched on my second question, but will you please work with staff to have that sent out to all the choice board members, the spreadsheets?
Yeah, absolutely.
You talked about other sources of funding. So that was my next question, because I know from my past experience with IHCDA that you often bundle programs and funding sources to make something work. So I wanted you to talk a little bit about that, and also how would you characterize the programs and funding sources you have access to in terms of meeting the need?
Yeah, great question. We do, as I mentioned, there's probably about 4 or 5 different types of funding that's used for capital, meaning for construction on that construction budget that IHCDA, depending on each deal's unique and has its own uniqueness to it. And some of the funding fits well with some doesn't. Most common, so I'll just list out. So the 9% credits stand on a loan, by themselves. Usually we'll fund with a not-for-profit. If a not-for-profit is involved, like an area agency on aging or a community action agency, they'll be eligible for home funds. Those are federal dollars. The Indiana Development Fund, that's a resource that we have. It's a revolving loan fund, provides some gap financing of about $500,000 on those deals. They all apply. For developments that are focused on permanent supportive housing, usually we're focused here on preventing homelessness. That's the National Housing Trust Fund. So there's 4 resources there. And then I mentioned the 4% and the bonds. What we do to help because it is kind of complicated in terms of each funding source, to help streamline the process, there's a universal application. So when a development comes to us, they apply for all those sources of funds that they're eligible for and that they need, because we do underwriting to make sure that there is a gap at the same time. So it is a universal application, one-time application review that's done. We don't break this up into trying to make them submit applications for each one of those funding sources. It's a universal application to really try to streamline that process for our developers. So that they have the when we make awards, from IHCDA standpoint, all the funding's in place. Now, there's probably other sources of funds that they're trying to leverage. We have been promoting Ready as another resource that we sometimes will see on some of these deals, which is great. There's permanent financing, so they're in the private market working with a construction lender and a permanent lender. Some of these deals will have bridge financing as well with the tax credit equity that comes in. But for us, it's one application that we receive. So there's that. I should mention every year, this application, the policy, this is our last round for this one. So we will be going out in December asking for public feedback on the policy. And we'll review to see, are we hitting geographically across the state? How many units did we hit that are age restricted and are workforce housing? And how many of them are in areas of opportunity, like where there's really, opportunities for employment, good schools? And then we'll look for areas where there's underserved. There may be areas where it's a revitalization. So we really try to create a policy that balances all of that out. And every time after we finish, after November 21st, we'll go start looking at and determining, how balanced were we? Were we able to get good geographic distribution? Were we able to get a sufficient number of units comparably that are age restricted versus workforce or non-age restricted? How do we do with rural versus urban? And so those are good policy evaluations that we always do. To your question about, is there enough resources? The need continues to be there for housing in general. You can call it senior housing, workforce housing, affordable, attainable. You can use all the buzzwords you want, but yeah, we have a gap, and we need to continue to hit all types of housing in our state. When that's new construction for home ownership, that's rehabbing our existing housing that we have. We have an aging housing stock across our state. And so for us, obviously there's about 37 applications on the 9%. We'll probably be able to do about 19 of those deals. So, for 2 to 1, 3 to 1. On the 4%, with the state tax credit, like I mentioned, we can do 5 deals. We got 18 applications. So again, 3 to 1, 3 applications to 1 that we can fund. So yeah, the resources are tight. The demand is strong. But we're trying to do the best we can with the resources we have and trying to leverage other resources that are out there. So.
Do you expect HUD funding to continue at current levels?
I think on a couple of them, no. I think we saw this year the home funds was a decrease. We normally get about 19 million. I think we had a cut of about million. So I think we're around 18 to 17.5 million of those dollars. Now the credits, they should be probably pretty close to being the same. The challenge is cost. We're having rising costs to total, construction cost. Those costs are, resulting in less units being created. That's a big challenge for us, or we're doing one less deal, one less development because of cost. Costs are a big concern for us, and something we've been working on. But the good thing is, yesterday the Feds did cut interest rates by 0.5 point yesterday. So hopefully some of that interest cost on construction and on permanent financing will be realized a little bit. Hopefully that can continue to come down a little bit to help with stabilize some of the cost. And but that is a big issue. That's a big challenge for us. Yeah.
Okay, well, thank you so much for talking with us this afternoon about this housing being such a major social determinant of health, and knowing this is really important. And thank you for updating us. We need to keep this conversation going, obviously. Yes, there's need out there. And I think of our local communities, and some are fairly slow in changing some zoning ordinances and recognizing some of the need for this. So continuing work across the state. So thank you very much, Jake, for your organization, your work.
Thank you.
Okay, I'm going to pause here, I think, Leslie, before your update, because Representative Claire had some comments and amendments to the minutes. So we could just pause and deal with that bit of housekeeping.
We don't have to deal with it right now. I was just questioning the minutes because I noticed that with the exception of Ms. Huckleberry, none of the comments or questions by any of the other members of the choice board are reflected in the minutes. So it would be good to redraft the minutes to reflect the not in granular detail necessarily, but to reflect the comments and questions of the members. For example, I think we're going to get to this again in a minute, but I calculated the wait list times. I remember based on the numbers you presented, and that's not reflected in the minutes. So I think there are just some gaps. So I would ask the staff to go back to the recording and see if we can make the minutes more accurately reflect the conversation that occurred in the meeting.
Okay, our staff will take that back and take a look at things and present an updated draft for comment and approval.
Okay,
Thank you.
thank you. I thought it might go into some things that we'd be asking today that you had raised last time. So that's why I paused and went to the minutes before we got the update.
And you did member recruitment before I arrived, didn't you?
Yes,
Yeah. Was there any progress?
no,
Did you get the recommendation from the ARC for the
yes. Well, I'm sorry.
disability?
I don't know what, take a look at that, see.
Yeah, where are we here? Organization that represents senior citizens or persons with disabilities. I think the ARC was providing a recommendation. Did you receive that?
I'll check with Erin. I think we have a couple that are pending on there. Erin made a.
Erin referenced something about ARC on there. I just.
Oh yeah, it does say a nomination was received from the ARC of Indiana. So good. Yeah, we just have to get them through the process. Thank you.
Okay, very good. All right, Leslie, your update today.
Yes, so in the interest of time, I'll give a quick choice update and then a waitlist update, and then defer the rest of my time to Kristen for her update. So just briefly wanted to update you all on the choice annual report. So that's in the process of getting a final draft put together, an internal review. And so Erin hopes to have that to the board for your review sometime around early October. So you guys have some time to review it prior to the meeting in November. That will have information about the reversion amount for the last fiscal year. So you'll be able to see that and some details surrounding that. So that should be coming here soon. Like I said, she's finalizing the draft and it's under internal review. So as long as we can move that through, we'll get it to you guys here pretty soon and you'll be able to take a look at that. Any questions about that or anything, I guess, about choice before I move into the other update?
Are you expecting any surprises on the reversion issue?
I don't know if it's any surprises. I mean, we do have an amount that reverted back this year, so we'll just be information on that. We're going to try and break that down in more detail so that everybody can see kind of what that looks like. And then, we are working to, hopefully, have some additional support within Division of Aging with choice. And so if we can get that finalized, then we'll have somebody that can, I think, proactively kind of help with monitoring that and working with the AAAs too.
I recall there are some administrative issues that contribute to the reversion in terms of
How we can shift money around.
how you can shift money around and who's providing services when as we get to the end of the fiscal year, right?
Yes, so part of why I'm not sharing the details today is because we have a couple conversations we want to have to make sure we understand what is behind some of the reversion amounts for different areas, so we can understand were there barriers to be aware of or kind of what that looks like. So hopefully we'll have that information to share in November too.
Yeah, I think we're on the same page
Yeah.
because when the reversion is always a concern, but when there's a waiting list, it's a greater concern.
Yes.
As I know you agree.
Yeah.
So, thank you.
So I'll give an update on the wait list for the pathways and health and wellness waivers. So we did publish, FSSA published a dashboard last month on our website that does show the number of invitations that are getting sent out per month. It does have September's invitation numbers on there. So we will send that link out to the board members after this meeting so that you have that and can access that. It does break it down by number of invitations for the pathways waiver, number of invitations for the health and wellness waiver, the number of invitations per month that are from the priority categories identified in the waivers, and then the number of invitations that are based on their level of care assessment dates. So as you look at that, you'll be able to see that the majority are based on that level of care assessment date. So folks that do join the wait list in one of those priority categories are getting moved to the top of the list and generally are getting invited pretty quickly. You'll also see that, our target, as we shared before, is 925 invitations per month across the two waivers. We did exceed that target amount each month as we either get information that, folks are declining it, no longer need access, have moved out of state, maybe have passed away, whatever the circumstances are that the person on the wait list is not going to move forward with pursuing that slot, then we try and assess, sending out more invitations. So you'll see a little bit more than the 925 per month. So far this waiver year, we've invited a little over 3,000 people total. The wait list figures themselves right now, as of late August, there were 13,679 individuals on the wait list across the two waivers. 9,248 of those were for the pathways waiver. 4,431 were for the health and wellness waiver. So we do continue to see demand for the waivers as we invite folks. Obviously, people are also getting added to the waiver wait list. So those numbers are somewhat fluid. So I know the question came up this morning of kind of how many are we seeing added per month. It's a little hard to track some of that because as we invite people up, that drops it, and then people kind of go on and people are added week to week. But we do, again, continue to see that demand exceed availability for the waivers. So we're doing what we can to obviously monitor that, working to monitor progress on people moving through that process. So we can determine, now that we're a couple months in, what's this looking like for folks? What can we do to increase the volume of invitations so we can move through this as quickly as we can, get folks connected to services as quickly as we can. So now that we're a couple months in, we're gonna, I think, start having a better sense of all of that as well. So we can assess, how can we increase that volume and kind of move folks through quickly as much as possible. Questions on any of that from folks?
I just did the math and rounded, we're still at 12-month waiting list on pathways and almost a 3-year waiting list on health and wellness, 35 months, again, rounded. So I'm glad that you're inviting more than the target numbers each month, but even with that, it looks like we're barely treading water. So, well, let's talk about a couple things. So it has been mentioned, I believe, the Medicaid director, Cora Steinmetz, talked in the last Medicaid Advisory Committee meeting about, in response to questioning about discussion of using ARPA money to bridge the gap. Where is that discussion?
So I want to make sure I understand the context of that. Was that using ARPA money to bridge the gap on like increasing the number of invitations that we're sending out, or in a different context?
Well, I think, one thing that we're seeing, the cohort that she was talking about, or where she said the discussion about ARPA money was occurring, was folks who had applied prior to applied and been approved prior to the wait list coming into effect in April.
Yes, so that's tied to assisted living in particular is where kind of we've been focusing that because that's intricately tied to their housing, right? So we are finalizing a grant in collaboration with assisted living providers that will focus on those folks who were moving through the process at the time the waitlist was implemented, may have already moved into the assisted living facility and then kind of got stuck because of that waitlist. So we're working to finalize that, I think, yet in the next, by the end of this month, hopefully, so that we can provide some targeted relief for those folks and some support on that end, because we know that group in particular, again, because it was tied to their housing, trying to provide some support there with that ARPA funding.
Well, when you say it was tied to their housing, you mean that they are spending down their assets, and once they spend down their assets, then they won't be able to pay for their housing in an assisted living facility if a waiver slot is not available.
Correct. So it's they pay their room and board even when they're on the waiver, but their assisted living services, yes, that would be the gap that's normally covered by the waiver. And if they've spent down and then have not yet been invited onto the waiver, then yes, that would be a gap for sure. That's what we're trying to target.
Right, but it's not. One of the questions I raised in the MAC was about why are we limiting it to assisted living, because there are folks who are trying to stay at home and are getting caught in this as well, and they could end up in an institutional setting if we don't provide a way to serve them in the gap in the interim.
Yeah, I mean, it's a hard situation, right? So, I mean, I think we're trying to be cognizant of what resources we do have available, what we can get started, because this funding that we're using has to be spent by the end of the calendar year. So, it's certainly not to say that folks in other community settings don't have a need. It's just, we understood that these folks are at particular risk for eviction. And so really trying to do what we can with the resources that we have to support who we can for this period of time.
I understand,
Yeah.
but I don't know why we can't do both. How much ARPA money is available for this?
We're still doing the math on what that's going to look like. I don't have the number in front of me.
Okay. I thought all of the ARPA money had to be committed by now. I thought it was all committed.
So the vast majority of it is committed. We have some projects that make adjustments over time. So like we had budgeted or estimated the budget at this. As we get closer to the end, hey, we're not spending all of this. We're going to have this amount remaining. So some of it is that
So,
type shaking out.
so from where is this ARPA money going to be reallocated?
So those projects are across the board, across the whole agency. So there are different pieces. Like I know, for example, Division of Aging, we've had one or two where we had estimated it would cost this much. It actually costs this much. It's not coming from any one particular project.
Okay, so it's just excess dollars from a number of sources. Right. But you don't know how many dollars.
I don't know, not offhand, no.
Yeah. But I understand the concern around assisted living, and I certainly share the concern, but I have, just as much concern for people who are trying to remain at home and need waiver services to remain at home. I mean, some of those folks may end up in a skilled nursing facility for lack of waiver services at home, right?
That's possible, yeah.
So, yeah, so again, I raised this at the MAC. What do we need to do to make that part of the conversation? Because it doesn't sound like it. like
So
became
I
part of
will,
the
I can
conversation.
take it back to our team internally to take more of a look at that. I mean, I wouldn't say it's not ever been part of the conversation. I think we have 3 months to stand this up and sort of get money out the door. And so trying to, again, think about how can we target this? How can we realistically do it? What do we actually have the funding to accomplish? And again, understanding that
Right.
in the end, it's a temporary fix and needing to, we're doing what we can to
Yeah.
bridge the gap for who we can in the
Yeah.
end, but if we had the funding, we would just have them on the waiver. So some of it's just doing what we can with what we have.
Sure. Well, it seems to me that the priority should be based on acuity, not housing setting.
Again, I think the challenge is how do you define that? How do you quantify that? How do we monitor it? How do you set it up? How do you get money out the door in the period of time we have to spend the dollars? So I don't disagree with you that there are certainly folks in the community that have a gap in services. That's why we have the waivers, because there's need and we know that the demand is high. I think there are those logistical pieces that we would have to figure out in a very short period of time, and that presents some challenges with being able to get the money used up before the end of the calendar year.
But to clarify the point, acuity is a different set.
Closer to the mic.
Acuity is a different set of criteria than housing. So there is criteria for acuity. So it looks like this isn't based on acuity, it's based on housing. I think that's your point.
Yes.
So we do have ways that it could be, the priorities could be based on acuity, not. So there is a way to do that, I think. So
I mean, we don't rank people on the waiver based on acuity today. So like, it's that sort of thing. We're like, how would we define acuity? And it's not, again, not to say that if we had the time and if we had the funding available for a period of time, we couldn't work through that. We're trying to tap into what do we have today that we can clearly define, get out the door and spend. And so that's, I think, part of the challenge with that.
Isn't that where case management comes in, though? I mean, shouldn't I mean, we have assessments and we have case managers, so shouldn't somebody know who's at greater risk of losing independence?
I think you could, but I think we would need to dig into what is an objective way to measure that criteria, because acuity could be something that's very subjective, right? I mean, somebody that you know and you work with, you feel like that person has an acute need, but you don't see everybody. So, I mean, it's just trying to figure out how would you measure that? And again, I'm not saying that it's not doable. My concern again would be, is it realistic to get through that in the period of time that we have? So, I mean, I can take this discussion back and talk about it with our team and explore do we have the funding? Is there a methodology we could apply and do something quickly to implement something? I just want to be transparent on what the challenges might be with that.
Sure. Well, I appreciate your desire to be transparent and, in that spirit, I think there should be transparency around the amount of funding that may be available. So that more than just your team, knows what's available and how it could be allocated.
And we do have reports on our website about all the different ARPA and HCBS funding. So that's more just that I can't rattle the number off. I'm not saying it's not out there and available. So
Sure,
we
but
can-
without being in your internal discussions,
Right.
the members of the choice board and members of the public and the media don't know which programs you're looking at as potential sources for funding, like where is, some excess money, right?
So I mean, all of that is like gets updated in our reports. I guess what I'm sharing is over time, some of that gets adjusted just based on estimates. So it's not. It all goes into what builds up all of that information that's out there.
Understood, but
Yeah.
but there's no way to look at the report and know as an outsider that a certain amount of excess funding is ultimately going to be available.
I'd have to go back and look at the report and see what level of detail it gets. I'm
Yeah.
sorry that I don't know that offhand, but
Yeah, no,
I know what we're doing. We've done some work to put on the website.
Yeah.
Here's how we're spending the dollars, what we're doing with everything and.
No, I appreciate that.
The different division, ABC community being one of them, right? So lots
Yeah.
of projects across the division. So I
Sure.
think it's just, again, as we're getting closer to the spend deadline too, some of that stuff becomes clear, right? Of like, oh, I have to spend this by 12/31. Maybe I'm not going to be able to spend
Right.
it the way I thought, right? So it's not a,
Well,
you know,
I just think that we ought to be prioritizing based on acuity
Yeah.
rather than
Yeah,
rather
two
than
of us
housing.
on For that. rather than-
When I see Stephanie continue to nod her head over there, I don't know if
Okay,
that's something
Stephanie.
else or
I'm
or
trying to
this.
look up the numbers. So
Okay.
this report's April 2024, 701 million in ARPA funds committed to home and community services. Of the ARPA, $2.1 billion, and that was 84% of the total budget has been invested to date. 55 million was committed to Pathways for Aging. It's just for the breakdown.
we can certainly follow up with information and share out links to different reports and information to the choice board. I know we're getting close on time, but
Yeah.
is there any other questions I can answer or?
Okay, so we're asking for more
Well-
information on
Yeah.
that issue. There's pushback and Stephanie's.
Well, and I think it is very time sensitive, but I appreciate the conversation. I just think that, again, acuity, should be, I mean, maybe there's a matrix, looking at housing stability and acuity, because I'm not suggesting that we want to see anyone displaced, from housing, but it just seems as though acuity should be a top priority as well. You're talking about, priority categories, so, a priority or the top priority category right now is, assisted living, maintaining, an assisted living unit that someone's already moved into, right?
So the priority categories I referenced earlier, they're priority categories in the waiver for folks that apply for the waiver. It outlines if you're in a nursing facility, if you're hospitalized, or if you are on a state funded service like
Mhm.
Choice, you get bumped to the top of the list. That's the priority category as identified in the waiver, and it's for access to the waiver. Yeah.
But being in an assisted living facility would be one of those categories.
It is not one of the priority categories in the waiver, no.
Okay. I'm not arguing with priority categories. It just distorts the wait list though, because some people, it's not a linear 12-month wait list for Pathways. Some people are effectively on a longer wait list because they don't score for the priority categories, right?
Yes, so if you're on the wait list and you're not in a priority category, anybody in a priority category gets moved to the top of the list. Though I will say, if you look at the number of invites, the vast majority are people by their level of care date. So it's,
Right.
so we get through those priority categories each month, basically.
Right, but that's my point is that there's a subset of people on the wait list who are going to continue to see other people move ahead of them in line.
Yes, yes. So that's why it's fluid. Yes.
Yeah.
That's what-
Well, you can't get on the choice services in parts of the state because you're on wait lists. So that knocks you down, even if you need services. So there's some issues there.
Yeah, and then the other thing that came up in the MAC was the making this ARPA money available for people who had not already gone through the application process prior to April. Obviously, there are new people going through the process all the time. So, I would think that we would have the same level of concern, for example, for someone who, decided in April or May that they needed to go into an assisted living facility and started that process and the spend down and all that. I mean, we don't want them to be left out. At least I wouldn't think we want them to be left out because of an arbitrary date in April. So I'm just saying, shouldn't the ARPA money be available potentially for folks who came in slightly after the wait list was announced?
So happy to take that back and look at it and look what we might be able to do with that. I mean, the April date was selected specifically because these were folks actively moving through the process.
Mhm.
And then the wait list was put in place. Folks that may have moved in after we already implemented the wait list were at least aware that, hey, there is a wait list for this service in place, right? So that's
Sure.
that was sort of the initial analysis, but I mean, yeah.
Agreed, but
Yeah.
need didn't stop
Yep, I
developing
agree.
just because a date came and went in April.
Yeah.
So again, I'm thinking about trying to help people avoid institutional care.
Yeah.
I understand what you're saying, but I wouldn't want an individual or a family to decide that a nursing home is the only option. If assisted living should be an option.
Yeah.
But for this date in April. Does that make sense? Okay. All right. I know we're out of time, so I'll be quiet.
Well, good issues to discuss, but yes, I'm going to move us along. Thank
Move us
you.
along.
Okay, did you have any other matters?
No, I will cede any other discussion. We're good. Thank you.
You're tired. Okay. All right. Anything else? Okay, thank you so much, Leslie, for your update. Kristen. The I-4A update.
Hello, given the time constraint, unless you have other questions, the only update I'll share is that we were very pleased that Senator Braun's office invited our Senior Medicare Patrol Program Director to provide testimony today in DC to the Senate Special Committee on Aging on Medicare fraud concerns. And there were 4 or 5 witnesses. She spoke as the expert on Senior Medicare Patrol. So we're thankful that his office has provided several opportunities to be helpful to the national policy discussion over the last couple of years. And this is the latest opportunity. So I haven't had a chance to watch the hearing yet or watch Nancy's testimony. I think we did a good job developing the testimony, and at least one person who watched it gave her a good shout out. So I'll be looking forward to seeing that. With that, I will defer any other updates unless there's anything in particular people want to hear about. Thank you.
Well, thank you so much. And you will be sending out some information.
Yes,
that
was, yes,
Your anthology.
The anthology. If you're newer to the choice board, I send out just a monthly information packet just to make you aware of things that are kind of happening in the aging and disability services world, and just given things that we're involved in lately. I didn't get that prepared for today, but hope to have something out next week.
It's always good information. Thank you.
Okay, is there any other business that needs to come forward to the choice board today? If not, thank you, everyone. We will see you in November.